Good afternoon and welcome to the Assembly of Osteopathic Graduate Medical Educators AOGME webinar series. We are pleased to have you join us for this AOGME webinar on rural GME development, HRSA funding for developing residencies, and THCGME program status updates, presented by Dr. Kent Voorhees and Dr. Alan Douglas. My name is Austin Wetmore. I'm the program manager for GME initiatives at ACOM, and I will help facilitate this webinar. Before we get started, I'd like to review a few housekeeping notes. This webinar is being recorded. The recording will be posted on the AOGME webpage shortly. All webinar participants are in listen-only mode. If you experience technical issues during the webinar, please use the chat feature and we will assist you. If you have questions for the presenters during the webinar, please feel free to submit them through the Q&A feature at any time. If time permits at the end of the webinar, they will respond to your questions. I will now briefly introduce our presenters. Kent Voorhees, MD, is an emeritus professor of clinical practice at the University of Colorado School of Medicine, Department of Family Medicine. Dr. Voorhees has been working in GME since 1992, and he has expertise in GME financing, advocacy, and rural program development. Dr. Voorhees has served on the RPS panel of consultants since 2010, and he also serves as a consultant for the HRSA Rural Residency Program Development and the Technical Assistance Center grants. Alan Douglas, MD, is a clinical professor at the University of Colorado School of Medicine. Prior to moving west, Dr. Douglas spent 31 years at Middlesex Health in Middleton, Connecticut, where he was the longtime family medicine residency director and DIO. Dr. Douglas joined the RPS panel of consultants in 2021, and he also trains new residency directors through service on the Academic Council of the National Institute for Program Director Development. I again want to thank both presenters for being with us today and for preparing this presentation. With that, I'll turn it over to our presenters.
If you were our first two presentations, they were mostly about Medicare GME, and this is about HRSA-funded THC GME funding and also rural program development funding, as well as how rural programs can be developed. So it's a little different than before, and it's going to be the third of three presentations about this. Next slide. Or next slide. So the THCGME program was actually established in the Affordable Care Act in 2010, and the first programs began in 2011. It's through HRSA, which is a grant-funded organization, and therefore requires authorization and reauthorization by Congress. And so the maximum, at least that was I understand, for HRSA funding is 5 years. And so it started the first time as a 5-year program. The intent, well, let me even go backwards. For Medicare GME funding, it only goes to hospitals. And so, academic health centers, academic hospitals get the funding, and they determine what specialties they want to train. That's often driven by financial reasons for certain programs and profit. And so HRSA decided they wanted to do something to help develop more doctors in rural and underserved communities, increasing their access, improving health outcomes. And that's where they came up with the THCGME program, which the funding actually goes to the community-based program or a consortium, which we'll talk about in just a little bit. So the entity is one, a community-based ambulatory patient care center, and two, it operates a primary care residency program. They may include federally qualified health centers, community mental health centers, rural health clinics, health centers operated by Indian Health Service, Title X family planning programs. So to qualify, the teaching health center entity has to be accredited as a sponsoring institution. That's important because you have to be accredited as a sponsoring institution before you can apply to be accredited for a residency program. And so what we often advise people that are going through this is kind of work on both simultaneously so that you hopefully get your sponsoring institution accreditation, and then the next day you can send in your program accreditation request. So the specialties that are allowed are family medicine, internal medicine, pediatrics, med peds, OBGYN, psychiatry, geriatrics, and dentistry. Next slide, please. So HRSA did a workforce analysis, and they estimated a shortage of 35,000 primary care physicians by 2035, and it's expected to be worse in rural areas. So why is the THCGME needed? Last year, THCGME residents treated over 792,000 patients during more than 1.2 million patient encounters. And again, those are in primary care access areas and underserved areas. So that was a big enhancement. Since the beginning of 2010, there have been just over 2,000 new primary care physicians and dentists enter the workforce. What you see below is the numbers of the different specialties. So about 1,200 family medicine, 466 internal medicine, 122 advanced general dentists, 107 pediatricians, and then the rest OBGYN, geriatrics, and psychiatry. And so 80% of the THCs are in community health centers, such as FQHCs, FQHC lookalikes, rural health clinics, and tribal health centers. Next slide, please. So in the most recent fiscal year, 2022-2023, THCGME funded 960 residents and 72 programs across, I don't think it's 27, my little thing's blocking it, but here, let me see, 23 states. And so that's a pretty broad representation across the country, and a lot of residents impacted, which, as far as I'm concerned, the more it continues, the harder it is to just defund it and close it. A policy brief from the Millikan Institute of School of Public Health and George Washington University, paper written by Candace Chen, who actually ran the HRSA THC program when it began, did an analysis, and CARE and THCs and their graduates produced a $1.8 billion in Medicare and Medicaid savings, with $1.5 billion in Medicaid and $284 million in Medicare. And I look at those figures, and they don't spend nearly that to run the program. So to me, it makes financial sense to continue this. Next slide, please. So THCGME funding can only be used for new positions. So as a result, you can start new programs, or you can expand existing programs, but you cannot have residents who are already in a program that maybe are unfunded and then say, well, we'll just cover them with this. It's not allowed. You must receive ACGME accreditation by July 1st after the notification. The notification has typically been November or December. And so I've seen programs that have gotten everything together, but they're not approved. They've been ACGME accredited, and they've actually waited for each year to see if, and not fill with residents, to see if they can get the funding. And if it goes 3 years without residents, then ACGME will pull the accreditation. Next slide, please. So some of the issues with THCGME is that it's always sort of been an uncertain future. It always requires ongoing appropriations and extension by Congress, and which means that it can fall into the area of the political arena, not just what's good to be funded. There have been variable payments. When it started, payments per resident per year started at $150,000, and they're supposed to go up this next fiscal year to $160,000 per resident per year. Those numbers are pretty accurate with what the academic costs are. The academic cost is primarily made up of resident salaries and benefits, program director salary and benefits, at least the non-clinical time, non-clinical faculty time, coordinator time, and clinical time is supposed to pay for itself. So that's not actually counted, but in consults we've done, that's been pretty much the range. The big issue is the funding is set to expire September 31st or September 30th of 2023. That's about 3 weeks from now. And so it's not been approved yet. We'll talk about some bills that will likely come through at the last minute. However, funding a residency, that's kind of a tough thing because you have to make a decision to whether you're going to match a program, match residents into a program before you know if there's going to be funding. And so the first time this came up, there were a bunch, it didn't get refunded, and they sort of juggled some of the leftover funding, and programs were going to get $70,000 per year. A bunch of programs quit, so that number then got distributed to a smaller number of programs. It went up some, but it definitely creates some uncertainty. And sometimes they've kicked it down the road for like 1 or 2 years as opposed to the 5 years. Institutional sponsorship. So as mentioned, academic institutions, if they want to participate, need to go in through a legally constituted consortium that includes the FQHC. The funding would still come to the consortium as opposed to the hospital or academic institution. It is possible, if you did it as an expansion, to have some of your residents in a program funded by one entity and a couple of others funded by another, but you want to try and work it out to where you don't have completely different policies for residents in each entity. And so they need to kind of work together. In addition, there are conflicting rules with CMS. Next slide. So when the legislative language was written about teaching health centers, it was specifically stated that the funding for teaching health centers would not impact Medicare GME funding to hospitals. Well, it came to a head at one point where there were Medicare or GME funding naive hospitals that had HRSA residents that came in. And then the question was, well, did it impact this setting of a PRA or start the cap clock? And in the meeting that they had between HRSA and CMS, CMS is the gorilla in the room, and they won. And so they say their rules apply and you have to figure it out. And the concern then is if the hospital's getting paid and the residents getting paid, or the consortium or the FQHC is getting paid, there's a potential for double dipping. Medicare doesn't, or the government doesn't like that. And so we actually were in a meeting yesterday trying to sort through some of this. And so it's complicated, but it's going to have to be probably some paying back of funds, it seems. So the issue of THCGME funded positions, not community support positions, that actually impacts a hospital trying to set a PRA. So we don't need to go into that at this point. Next slide. So the status for future funding, as I mentioned, waiting until the last minute, literally, does not work well for deciding about matching a program. But I think some people have felt like, well, it's going to be refunded because we've continued to get it so far. Actually, Children's Hospital, Children's GME is also funded through HRSA, and they get the grant funding that's reapproved. So I think some people feel like it falls in sort of a similar category. So there's a major bill in Congress right now, HR 3561, called the Patient Act. It's a big bill, and in fact, funding bills often get rolled up into these bigger bills. So in this one, it's a 108-page bill teaching health centers on page 89 and 90, so only 2 pages, and it calls for an escalation every couple of years of the amount of funding, as you can see on the slide. It was introduced by Kathy Morris Rogers, who was a chair of the House Energy and Commerce Committee. The important thing here is that it had 79 co-sponsors with 43 Republicans and 36 Democrats, so bipartisan support. So the hope is that this will go through and be passed by the end of this month. There's also a bill that's been introduced since 2021 called the DOC Act, or Doctors of Community Act. It also has been supported by ranking members in the major committees that involve these funding issues, which is an important thing as well. It was going to expand teaching health centers to a total of $6 billion over 10 years, create over 100 new centers for a total of about 200, add 1,600 resident slots for a total of about 3,000, and have the amount of money go up each year by the Consumer Price Index Urban. And so the issue here is that it was introduced by Frank Pallone, who at the first time he entered it was the chair, I think, of the Energy and Commerce, and now he's just a ranking member, but the co-sponsors are all Democrats. So it needs to garner some bipartisan support, which to me makes sense, that if you are in a state that has rural and underserved areas, that this would be a real helpful thing for your state. So maybe we can get people to try and vote on what's good for their states. Next slide, please. So for the THCPD, which is the Teaching Health Center Program Development, or also you'll see THCPD TAC, which the TAC is the Technical Assistance Center. Grants are $500,000 over 2 years. So ordinarily there are no funds for developing a program. Medicare doesn't provide funds, but this grant helps to do that. The RRPD, which Dr. Douglas will talk about, is $750,000 over 3 years, and had the TAC, and I think that was the idea that stimulated this for the teaching health centers. So the first cohort of the THCPD programs funded a total of 38 grantees, 29 of which are family medicine. Second cohort, 46 grantees. There's hope that future funds will be available. The Technical Assistance Center provides an advisor for the programs, and actually Dr. Douglas and I are advisors for these grants. So for THCPD, the participants are expected to achieve HCGME accreditation by the end of the second year, and recruitment of residents by at least the end of the third year. If they're not ready, they may receive a no-cost extension. The thing to remember is it's not just the accreditation for the program, they also have to be accredited as a sponsoring institution. So it's trying to bite off a fair amount in a short period of time. Next slide. So the requirements to apply, you must not have HCGME approval at the time of the application. It's possible to apply for both the THCPD TAC and the RRPD TAC from the same institution at the same time, but not for the same resident position. So if you're a large institution and maybe have sites across a part of the state, and some of them wanted to do a rural funded program and some urban funded, you can actually apply for both. As mentioned, an advisor is provided, and if outside consultation is needed, then that can be arranged as part of the funding. So the funding can be used for curriculum development, recruitment, training, and retention of residents and faculty salaries during development. The Technical Assistance Center is funded at the University of North Carolina. There's a link to a website that has a lot of information about what I just said and other things that were not mentioned because of time. And it can be used. You don't have to be a THCPD grantee to be able to use the website. Next slide. Turn it over to Dr. Douglas.
Well, thank you, Dr. Voorhees. Good afternoon, everybody. I've been tasked with talking about financial opportunities in the rural training of residents. And as I reflected on this, this is obviously a very broad topic. And it's a topic that's been in discussion for a long time. If we look back 30 years or so, there have been a number of efforts by Congress to provide relief for rural hospitals, both in general, but in particular in the area of GME. And there have been a couple of capstone events that we need to mention because they affect our future conversation. The first is when we think about the late 90s, when caps were set in as part of the Balanced Budget Agreement in 1996, rural hospitals were allowed to increase their GME and IME caps by 30%, and to start new residency programs, allowing them to further increase their caps. And urban hospitals couldn't do that. Many of you may remember rural training track legislation in the 90s. There have been several efforts at reallocating unused caps. Those were supposed to favor rural, but didn't actually kind of work out that way. However, in the CAA in 2021, there were several changes there that favored rural training. And the counterpoint to the Teaching Health Center grants that Dr. Voorhees was just talking about exists, which is the Rural Residency Development Grant Program, which is also funded by HRSA. So a number of efforts have been made over the years here. And as I reflected on what to talk about, I decided that there were probably three areas that were worth a conversation today. The first is, how do we define rural in terms of the financial pieces of GME, and what are the benefits financially of being a rural training hospital? The second is this concept of the rural training program, which exists both within CMS and within HCGME, and what are the financial benefits of that? And then third, I wanted to talk a little bit about this Rural Residency Development Program grants, which are funded by HRSA. So next slide, please. So first of all, we got to talk about how we define rural. And any of you who've been working in the rural space for a while know there are 20 different ways you can define rural in this country. If we talk from a CMS perspective, there are actually two pieces we always need to keep in mind. One is the physical location of a teaching hospital, and the second is the classification of those hospitals. And those may or may not be the same these days. If we go back 30, 40, 50 years, it was very clear. Urban hospitals were in geographically urban places, and rural hospitals were not. And it was all very clear. And almost everybody was either urban location, urban classification, or rural location, rural classification. But over the last 20 years, we've been seeing a lot of divergence in that, and having hospitals that are urban location but rurally classified, or the reverse. And this trend has really accelerated in the last 5 years. Now, here's the key piece that you all need to remember, which is that CMS has ruled that location, meaning geographic place, drives all the rules around DGME and whether you can increase your DGME funding when you open a new program, while a hospital's classification drives all the rules affecting IME. So those two designations drive two different things in CMS language. And it's worth mentioning the most significant divergence here, which has really accelerated over the last 5 to 8 years, which is the growing number of reclassified rural referral centers. Since 2014, we've seen almost a tripling of the number of rural referral centers, and almost all of that increase are hospitals in urban areas. And we've seen a rise over the last 8 years from 4% of all US residents being trained in rural referral centers to 52% of all the residents in this country are now being trained in a rural referral center. And we've seen an increase in the number of IME slots by over 12,000 through some of the benefits of becoming a rural referral center. So this has been a gigantic change in the game. Next slide. So how do we define rural? Well, it really, from a CMS perspective, all comes down to CBSA, core-based statistical areas. And many of you are probably Googling census CBSA maps right now. Go for it. And this is a graphical way to look at it. These are based on census data and therefore updated every 10 years, occasionally with interim adjustments. And if you look at one of these maps, like many of you are right now, you'll see the whole country is either white, light green, or dark green. And an area that's dark green means you're in a metropolitan CBSA. That means you're urban. If you're light green, you're in a micropolitan area. And if you're in a white area, it means you're not in a CBSA at all because the population density is so low. If you're either light green or white, that means you're rural. If you're dark green, it means you're urban. It's as simple as that. But figuring it out for a specific hospital gets a little tricky just from a map. So next slide, please. So what CMS does is it takes those CBSAs and crosswalks them into urban and rural designations for each hospital. And when they put out their final rules every year, they list every hospital in the country and are specified whether it's rural or urban. And I've provided the web link here if you're interested in going digging and finding the crosswalk file and looking up any specific hospital. But there's an even easier way than that. Next slide, please. So go to ruralgme.org, which is the website for the Technical Assistance Center funded by HRSA for the Rural Residency Development Program. You can register for free and log in, and there's something called the Hospital Analyzer, and you can actually select a state and select a specific hospital and find out everything you need to know about it from a GME perspective. So on the next slide, please, here's a graphic representation of it. So in your upper left-hand corner, here's the home page where you can log in through the portal, which is the links at the top right, which takes you to the next screen where you can click onto the Hospital Analyzer, which gives you the screen in the lower part that you can see. And you can select a state and a city, and it will give you a list of every hospital there. And if you click on any one of those hot links, next slide, please, it'll give you a report about that hospital. And I only display part of a sample hospital report here, but it will tell you what kind of a CBSA it's in. It will tell you whether it's classified as rural or urban, both by CMS, but also by FORHIP, which has some implications for grant funding, like our RPD grants. It tells you what kind of a hospital it is, whether it's a critical access hospital, so a community hospital, Medicare dependent hospital, blah, blah, blah. And it tells you whether it's ever claimed before, which has all kinds of implication if you're starting new programs. So this is, I think, the most valuable, simple way to find out the status of any hospital in the United States. And this data is updated annually. And I encourage you to sign up and use this tool. It's really helpful. Next slide, please. Okay. This is a slide that Lou Sanders showed you on our last webinar, but I want to go through it again because through a rural lens, this slide summarizes everything you need to know if you're making a decision about starting a new residency program, whether you have the potential to increase either your DGME or your IME funding. So the first row are in green, are GME naive IPPS hospitals. These are hospitals with no cap yet. They're naive. They start a new program. They can enter a 5-year cap clock and set a PRA, and they can get DGME and IME they never had before. They're starting from zero, and they can, depending on the size of the program and a lot of variables, they can build a significant amount of CMS funding in support of the academic side of the program. On the other hand, these other 4 categories refer to those 2 classifications of hospital we talked about: physical location and classification. So an urban hospital is a hospital located in an urban place, which is classified as urban by CMS. And if that hospital has already been capped, whether it was pre-1996 and got capped out then, or started residencies after that, ran a 5-year cap clock and achieved cap, that hospital can start other residencies if it wants, but they're not going to get any more DGME or IME because they're already capped out. On the other hand, a rurally located hospital, which is also rurally classified, can increase both its DME and its IME by starting new programs. If you have in orange an urbanly located hospital, which is now classified as rural, which is this rural reclass phenomenon I talked about a few minutes ago, that's already capped, because DGME is driven by CMS off your physical location, that hospital does not have the ability to increase their DGME if they start a new program, add new residents. But if they start a new program, they can increase their IME because their classification is rural. And this links back to that decision in 1996 in the Balanced Budget Agreement of allowing rural hospitals to increase their IME by 30%. And so this still applies today. And this is one of the benefits of reclassifying, not the only one. And then finally, the rare case of the Lugar Hospital, which is a rurally located hospital that is classified by CMS as urban. And there's only 98 Lugar counties in this country. It's a very small number of hospitals. But if they're already capped out, because they're rurally located, if they start a new program, they could increase their DGME payment. But because they're urban classified, they cannot increase their IME. Now, that's a niche case because there just aren't very many Lugar hospitals, but that's the other opportunity here. So I hope that little review was helpful. Next slide, please. So the next thing I'd like to talk about is rural training programs. I mentioned a while ago in the 90s, we had rural training tracks, and a couple of years ago, both first CMS and then HCGME designated special rural training programs. These are programs that are either a separately accredited residency program or a track within an existing accredited program as of 2021, where 50% or more, or greater than 50% of training takes place in a rural place outside of a metropolitan CBSA, in either the light green or the white on the map. Now, that 51% or more of training can happen in a rural hospital, or it can happen in a rural non-hospital patient care site, or some combination that adds up to more than 50%. And actually, some rural training programs have no rural hospital at all. They do their hospital training at an urban site and do all their outpatient time in a rural setting. And if that's more than 50%, you qualify as a rural training program. So next slide. So what's the benefit of a rural training program from a financial perspective? Well, the deal here is the urban partner in a rural training program can claim resident training time in a rural training program and get a cap adjustment, and therefore get paid above their historical cap if they're already capped. It's called an RTP cap. So an urban hospital RTP cap is set after 5 years for hospitals that already have a cap. So they essentially go into another cap building period when they start a rural training program for an additional cap that goes on top of the cap they already have. But they can't use this RTP cap for other non-rural training program residencies. So for example, if they start an RTP and then it closes, they can't take those cap positions in their RTP cap and apply it to something else. It can only be used for rural training programs. And if a rural training, if an urban hospital already has a rural training program cap, they can actually start another rural training program and increase that RTP cap, as long as that second program is in a different specialty. And there's also another little piece there that is still not totally defined. But if you start a second rural training program in the same specialty, but it's in a different rural community, you may technically be able to increase that cap too, but that case law has not been set yet. So I wouldn't count on that one. And in an RTP, a rural partner who claims some of a resident's time, the rural time they spent, might also be able to make a cap adjustment because they're a rural hospital and therefore they can float up their caps. Next slide. So this then leads to the great conundrum when you're setting up rural training programs where you're partnering an urban institution with a rural institution. Who's claiming that resident time? And the long and the short of it is there are now infinite variations on this theme. In the old RTP days, it was all very straightforward. RTT days, it was all very straightforward. The urban hospital claimed the urban time, and then the rural hospital claimed the rural time, and it was all very clean. These days, you can mix and match as long as you're in an agreement that defines who's claiming what. And it can go a lot of different ways. And I'm not going to get into the details here because we could go on and on about this. But suffice it to say, there are infinite variations on this theme for a consortium that's sponsoring a rural training program. Next slide. So there's some caveats here that I think are really important to understand. Both HCGME and CMS have embraced this concept of the rural training program. And earlier this year, the HCGME moved its definitions largely in line with CMS's definitions, which has helped a lot. But to be clear, just because HCGME designates a new program as a rural training program does not guarantee that CMS is going to pay as a rural training program. And just because CMS designates a rural training program does not guarantee HCGME is going to designate it as such. You've got to please both masters if you want to achieve both the accreditation and the financial benefits here. There are also some historic family medicine rural training tracks out there that have still not been designated as rural training programs because this has been a fairly recent change. And I also just want to say, although there are some financial advantages potentially, especially for the urban partner, of setting up a rural training program under the current rules, even if you're not a rural training program, you can still provide valuable rural training to your residents. Even if your major teaching sites are not in a rural CBSA, or if you used to be in a rural CBSA and then the census came along and changed you to a metropolitan CBSA, or if for whatever reason you're providing less than 50% of the training in a rural place, that doesn't mean you're not providing good rural training. It just means you may not qualify for a particular source of funding. So don't devalue rural training happening in programs that aren't participating in an RTP. Rural training matters however you can do it. Next slide. Now, finally, I'd like to finish by talking a little bit about the HRSA-funded Rural Residency Development Program that Dr. Voorhees already hinted at. So this is the parallel to the THCGME development grant program. As Dr. Voorhees mentioned, the Rural Residency Development Program, RPD program, came first. And it's a 3-year program with $250,000 per year for 3 years, total of $750,000. And frankly, a 3-year development timeline to get accredited as a sponsoring institution, develop a program, get the program accredited is a much more breathable space than the 2-year timeline on the THCGME development grants, which is really, really tight. There have been 5 cohorts funded so far for a total of 76 grantees, an additional 17 grantees. The 5th cohort just started in April of this year. And it's anticipated that future funds may become available because this has been a pretty successful program. The Technical Assistance Center that Dr. Voorhees and I both work for as grant advisors has been around since 2018. The Tax Center provides an advisor to each grantee, a whole variety of program development resources. There's some independent consultation funding available through the Tax Center in addition to any consultation funding a grantee wrote into their grant. And there's an annual meeting of grantees, 2-day meeting. It's next week in DC, and is really valuable for the grantees to meet each other or get additional technical assistance. So there's a lot of resources there in this grant opportunity. Next slide. So what are the eligibility requirements to apply for an RPD grant? A rural partner must be the applicant or must be an integral part of an obligated stakeholder group if the applicant's an urban hospital. So in other words, there needs to be a legally written agreement about who's participating and doing what here if the application is not coming from a rural partner directly. The proposed program must train their residents more than 50% time in a rural place. Now, here's a key distinction between that pretty firm CMS definition of rural, meaning you're not in a metropolitan CBSA. In terms of this HRSA grant opportunity, you can qualify either by being in a CMS defined rural place, as we talked about, or being in a 4HIP defined rural place with a RUC score greater than 4. Now, that's for the purposes, to be clear, of being eligible for an RPD grant. If you are not in a CMS-defined rural place, you're not eligible for CMS payment under the rural hospital designations. These grants are eligible in about 6 or 7 different primary care specialties, which you can see listed on the screen. The proposed program can be either a separately accredited new program, what the HCGME calls RTP type 1s, or you can be a new rural track of an existing program. I've worked with both of these, which is what the HCGME calls an RTP type 2. You must not have already achieved HCGME accreditation at the time of application. The reason for this is these grants are designed to help you achieve HCGME accreditation. So if you already had it, that's not the point of this grant opportunity. These programs must have a realistic, committed plan for sustained program funding. These grants are to help programs support that unfunded work that has to happen for several years before the first resident arrives and they suddenly are eligible for CMS or other funding. Most of these programs are looking at funding through the CMS Rural Training Program qualification. And the proposed timeline must include successful HCGME accreditation by the end of the 3rd grant year, but they need not have recruited their first class until 1 year later. Next slide. All right, so we are sitting here at 2:45. So we've got 15 minutes for questions. Austin, thank you. Would you mind synopsizing some of the questions that went into the Q&A? Dr. Voorhees and I will attempt to answer them for you.
Yeah, we had one question. It was, when funded by HRSA/THCGME, what is the typical framework to pay a partnering hospital hosting residents for inpatient IM, EM, OB experiences, etc.? The hospital isn't receiving CMS funding, correct? Does the sponsoring institution for the family medicine residency, in this case, in FQHC, typically pay the hospital?
So, yeah, I saw that and I thought it'd be easier to explain speaking about it than trying to write an answer. I did write an answer to somebody else's question that was on the chat as opposed to the Q&A. So this one was by Cliff Knight. Hi, Cliff.
Hey, Cliff.
So the biggest question is, it depends. It's a negotiation that has to be worked out between the new program and the hospital. If the new program is paying all of the expenses, which include resident salary and benefits, then no, they wouldn't ordinarily pay the hospital. If anything, the hospital's getting extra work out of them, and you'd think they might want to pay the program. If they were eligible for CMS funding, then that's where the conflict arises. And if the hospital got funding from Medicare and used that to help pay for some of the expenses, and then the program got teaching health center funding to the full amount, the program would probably have to pay some of that back to HRSA. And so I have to say that the meeting we were in yesterday, there were a couple of lawyers that do this work nationally, and I think they're confused by what all the different scenarios might hold. But so I think it would be outlined in a program letter of agreement or a master affiliation agreement, although technically master affiliation agreements are no longer required. But a program letter of agreement would say who's going to pay what. But I have not seen the hospitals pay, the programs pay, except for things that are in short supply. So like OB backup, I've seen programs pay, not necessarily the hospital, but a practice for helping to provide OB backup, but ordinarily not an exchange of dollars if it's worked out in advance, and each entity, who knows who's getting what.
So to build on what Kent said, I think the key concept here is that the federal government does not want to pay twice for a given resident through two separate programs. And if you have a residency program through a teaching health center that's receiving $160,000 per year per resident to support the academic side of that resident's education, if you also have a hospital receiving additional CMS funding for that resident as well, that's double dipping, and that's not okay. There has not been a lot of audit-based case law yet on exactly how the mechanism will work for paying that money back to the feds. Those audits are just starting to happen right now. I would bet in another 3-4 years, CMS and HRSA will have worked out some kind of a mechanism. The problem here is HRSA is the flexible one, CMS is the gorilla and the inflexible one. They're not negotiating on an even level. And until this case law works itself out, I don't think anybody knows quite the answer. But if you're setting up a new program, I'd be very careful about making sure that double dipping was not going on, because that could be very problematic 3 or 4 years down the road. And you wouldn't want to find yourself in the middle of a disputed audit over that.
And so our other question was submitted through the chat, so I'm not sure if everyone can see it, but it was, are inner city medically underserved psychiatry residencies eligible for the THCPD grants?
And I think that's the one I answered in the chat, which said the answer would be if they're one of those entities that is required to be eligible for the THC funding. So that included a federally qualified health center, rural health clinic, community mental health center, Indian Health Service. And so if they're one of those, they would be eligible. If they're not one of those, they would not be eligible.
And the ticket there is psychiatry requires a substantial inpatient component of training. So there would have to be a hospital partner in there somewhere.
And there are quite a few psychiatry programs that are in the THCPD program now. So there are certainly some that are meeting those specific criteria, but that's the issue, is what entity are they in? There was another one, Austin, that I see it under dismiss, but I can answer it, where Megan Ruddy was saying that THCPD mechanism was included in the ACA and is in Title VII of the PHS Act. So I'm making an educated guess here, but bills can get passed, but the funding will have to be authorized by Congress. And so the example was the National Advisory Board. So it was going to like put a brain to the Medicare or the GME funding system in the United States, and they were not funded. They even had the people picked, and they knew the length of the term, and they were not funded. So they even volunteered to do the work free, and they were not allowed to do it unless they were funded. So that was part of the ACA also. So I think the RRPD had to be funded before it sort of got rolled out, which I think was, what did we say, 2021, or it might have been a little earlier, but not exactly at that time.
I also think it's worthwhile, especially as we sit here towards the end of the third webinar in this series, to just go up to 40,000 feet for a minute, which is, if you're thinking about starting a new residency program, there's a cost associated with that. In the average family medicine program out there, the cost of running a program is a little bit over $300,000 per year per resident in aggregate. At a teaching health center, it's a little bit less than that. It's in the high 270s or something like that in the most recent publication. And so you've got to pay for that cost somehow. And you're always going to have clinical revenue, which will cover a significant chunk of that, but you've got to cover the academic costs of the program. The program director's salary, the non-clinical part of the faculty's salary, the coordinator, the software. I could go on and on, right? So that's where you need to think creatively in designing your program about where to get that money from. And traditionally, most of the funding's been through CMS. It's got the advantage of being a steady stream that is predictable. It's got a number of downsides. The funding is not available easily to many hospitals for additional slots above their caps. There's a vast variation in per resident amounts across this country and across institutions, even within states. So, there are downsides there too. Medicaid funding is growing rapidly in many states. In some states, it's practically a bonanza. The numbers are the amount per resident being supported by Medicaid, especially in rural areas in many states right now, is pretty amazing. So that is a growing source of funding. If you're basing a program in a teaching health center, that's a very helpful steady stream of funding, but it's subject to reappropriation. And now that we sit 3 weeks from the deadline without new funding appropriated, and there's some less than pretty history here, that's maybe not as comfortable a funding source for some as CMS funding, but it's a new stream that people are eligible for in certain settings. And there are other places you can find, academic funding for a program from too, whether it's the Veterans Administration, whether it's grants and contracts. There are a lot of things you can do. So I just encourage you all to think creatively if you're thinking of opening a new program, and don't just stick your head in one box, the CMS box. Think about all the different other boxes too, and put together a combination of funding sources for that academic side of your program, which is probably about half of the total cost per resident. And put together a package that will work for you based on where your program is based, both geographically, what kind of an institution, what streams are available to you, and put together a plan that works for you. The plan that works for one program will not be the plan that works for another program.
Well, I was going to just comparing Medicare GME funding and teaching health center funding. Medicare GME funding is an entitlement program. So that means that if you meet their requirements, they have to pay you.
You can have it forever.
And so it's not like they're going to select you. However, the teaching health center funding is a selection process, a competitive selection process. So you can actually have all the pieces in place and not be selected. And so it's a little riskier there. Once you're in, once you're part of the club, and if they're going to be doing continued reauthorizations, then you're likely going to be refunded. But getting in the door the first time is indeed not the same, where you can actually have everything properly in place but not be selected.
I'm looking at the Q&A. There's a question about when's the next predicted NOFO for the RPD and THCPD. My understanding is there is an intention to offer those and some preparation for that, but until Congress acts, people are not moving on that in terms of implementing them. And then there's a question, could you clarify that receiving a THCPD grant is not connected to approval for THCGME funding? And my understanding is that's correct.
Right. So they, like this last go around, there were 40-something programs selected, and there's no guarantee that by being a part of the THCPD that you'll be selected to be one of the programs that they actually approved to fund. You would think that HRSA, trying to select all these different people for helping to develop their program, are not doing it to be a waste of time and have some hope and knowledge that they will eventually be approved, but they are two separate things.
And I'd like to thank Lori Rodefeld. Hi, Lori, who's put out there. There's a NOFO projected for RRPD funding for November of 2023. Now that has not happened yet, but it's projected. Thank you, Lori, for that clarification.
Awesome. Thank you so much. In the interest of time, I think we're going to wrap it up. Thank you, Dr. Voorhees and Dr. Douglas, for this great presentation, and to all who joined us. If you have any questions, please contact us directly at aogme@acom.org. This concludes our webinar. Thanks again to everyone who joined us, and have a great evening.